My name is Matt Zygmont. I'm an associate professor of radiology at Emory. I co-chair our CT Quality and Safety Committee with our department. And I'd like to tell you about our experience, and there's so many similarities for our experience with Dr. Pike's experience, and I hope that I can shed some light on how we do things maybe a little bit differently, and some of the lessons, same lessons that we've learned as well. I don't have any disclosures, and so in our time together, I just wanted to go over the why, which Dr. Smith-Byman has already given you a great overview, so we'll move quickly through that. I'll talk a little bit about what our mandate is as CT imagers, give you some background on our institution and what our challenges were. And then I wanted to walk you through our timeline of how we establish structure and process in CT to both make sure that we were compliant with Joint Commission rules and then also eliminated variability in our process, created standard work, improved quality, and a consistent work product for our CT exams. And then I've got a few lessons learned, and I'll talk to you a little bit about the opportunities that I see for our practice. Super interesting to hear that Dr. Pike already has an electronic image quality monitoring system through Alara. That's something we haven't been able to do, but it's on my wish list. So as you guys have already seen, medical radiation is one of the largest sources of exposure to the US population, and it's seen huge growth, and now CT is such a large part of that. And Dr. Smith-Byman walked us through all the evidence to showing why that increased exposure is a risk to the population. In addition to that, Emory also participated in Partnership for Dose, and it just exposed that there's so much national variability. And then I think we can all agree that when you look at individual institutions, just the variability in types of scanners and the differences between sites, local sites, also contributes to huge variability. And so this is a major challenge, especially for larger systems. And we've continued to see growth. This chart is our institutional for just the Emory system. We've seen huge growth recently. We are now doing 260,000 studies on the Emory side. We do 120,000 studies just in the Grady Memorial Health System, which houses our level 1 trauma center and our comprehensive stroke center for the Metro Atlanta area. So we're doing a lot of CT for our patients. And so being standardized is more important than ever. And so as CT imagers, all of us are, pledged. Basically, we have a commitment to image wisely. And I'm sure you all have seen this, but not only do we have, are we required to put the patient safety first, but we have to communicate why it's important to optimize our dose, not just to our colleagues, but to the other parts of the imaging team, the other teams in the facility who may not have as much experience with the scanners that we do. And then, we're beholden to review often to make sure that we're doing a good job. So just to give you a little background about us, we have now it's almost 24 locations. We have an install base of at least, I think it's 42 scanners currently across 3 different vendors. And as you can imagine, being tertiary care, having multiple tertiary care centers, we have a lot of subspecialty protocols. Our physician group for radiology is quite large. And so there's a lot of demand for the subspecialty exams. And so the question becomes, how do you standardize your work and maintain the requirements the Joint Commission has set forth for us? And so that's what I'm going to walk you through a little bit. So just to give everyone an overview, for those of you who may not be familiar, in the U.S. a number of years ago, the Joint Commission set forth new regulations for CT that requires the organization to document some sort of dose measure for every examination. They also want our protocols to be reviewed and kept current, and they require input from all stakeholders, and that includes the radiologist, the med physicist, and the frontline operations staff. Not only that, we're required to review and analyze incidents that we determine exceed expected ranges. So, our mandate becomes the following. We basically have 5 things that we have to do, and we have to do them well, we have to do them efficiently, and we have to do them continuously. We have to maintain our protocols, we have to track dose, we have to have some sort of threshold, and we need to investigate alerts. And one thing that I didn't speak to, we're supposed to benchmark to an external source. And so that for most of us means participating in a registry. So that's where we are. And to do that is hugely challenging because, as you can see, if you're in a bigger institution, you're scattered across a large metro area. You have lots of staff that you have to communicate with effectively. This becomes a big problem. And it's not an easy solution. It becomes a labor of love, like Dr. Pike was saying. So the way we started, and this is sort of how we approached it, 13 years ago, we decided we were going to define our team. We aggressively secured time and resources, and I'll talk a little bit about what that means. And then we established a process by first standardizing. Then we went through several cycles of optimizing, and now we're in a phase where we continually review our performance. And, part of the securing time and resources, the resource part, you have to have, good technical knowledge. Sorry, skipped here. Having expertise and really understanding your equipment is so crucial. And I've got an example, just like Dr. Pike, where we had a scanner upgrade, and there was a feature change that basically took our doses out of line. And I'll show you what that looks like and how to check for that and be aware of that. But that is something that you have to have. You have to have that technical expertise. And we've done that in a couple of different ways. I'm super lucky that on my team, I've got 2 really knowledgeable medical physicists. They not only do they know the scanners inside and out, their attention to detail probably compares to none, and they have a excellent skill set when it comes to data analysis. So all of those things sort of help us. It helped us get to where we are, honestly. In terms of securing time and resources, you need to make sure that you have leadership buy-in, that they provide administrative time, and resources are not just time, but it's also IT infrastructure. If you need data analysis, it's capital to purchase the software subscriptions that you may need for dose tracking, among other things. So this is vitally important. And one of the ways that we've piggybacked sort of the time and resources conversation with administration is that you can build a business use case for how standardizing workflow can actually improve efficiency on your scanners. and I'm happy to talk a little bit more about that later. But it's one way to sort of secure a quality team, you know, in the light of resource optimization at the same time, and you can do both hand in hand. So our team looks like this. We've got our frontline technologists, usually site supervisors. I will say we don't always have representation from all of the shifts, but we do have forms of global communication to get the word out on changes. That was a question that was in the chat earlier. We encourage physician input as much as possible, and we have a structure on our CT Quality and Safety Committee where each division has representation, and they guide the subspecialty protocol development with our med physics team, hand in hand with the frontline technologists, so that, you know, whatever changes we're making, we know will work for the clinical workflow. I'm super lucky that we have 2 physicists. Honestly, we probably need 4, and I'm working to get that. And then, super important, you have to have administration on board. They have to be aware. There has to be visibility and, you know, a bidirectional flow of information between the quality and safety team and what goes on with the operations leaders. So that's what our team looks like. So now I want to share with you our standardized workflow, and I can, since we've already talked a lot about, you know, some of the best practices and what the history is behind all of this, I can get into the weeds a little bit more about what our solution was. There's no one way to do this. I just thought I would share with you the way we did it, and maybe there's parallels that you can take away or find useful. When we started this back in 2010, kind of like Dr. Pike, we realized that we had so many different protocols that had been created for specific doctors by specific techs. Our scanners were not locked down. So the first thing that we did was we took all of our protocols and we identified what we needed. And we created a standard language of labeling our protocols. And really what it encompassed was having this 2-letter and a number designation. So for example, this routine chest without protocol is our CH1 protocol. And this is so powerful because on our scanners, if the protocol doesn't have a 2-letter number designation, we know it's not sanctioned. And when residents or fellows or faculty need to communicate with the staff about what the expectation is, all we have to do is give them a 2-letter and a number designation. And the tech knows exactly what we expect and how we expect to do it. And so this was our first step. We standardized how we were going to call our protocols. And to be honest, it's easy because then this allows us to place into buckets in our dose monitoring software all like protocols. So anything with CH1, doesn't matter what you add to the end of it, will sort of get lumped into the same protocol or the same bucket of monitoring, and we expect the same performance. The next thing we did was we pulled all the technical standards from across our system. We basically pulled every parameter off every scanner, and then we had the physician champions for each division review the different scanners and select the scanners that had what we considered the best image quality, or the image quality that they were willing to accept. And then we formulated a central repository of what our technical standards were going to be. That was a huge lift. And a lot of this work happened before I was part of the team. But nonetheless, I mean, this is the work that has to be done. And then those technical standards were made available to everyone, and they were put in an electronic repository. So in one sort of major push that took several months, we were able to establish what we defined as, this is our standard of care, this is our standard work, and this was the expectation that we wanted from everyone. And, some of the comments in the chat were, how do you help get um, consensus behind these changes, and how do you motivate the staff to accept changes when they've been doing it a certain way for a long time? This requires a lot of outreach and a lot of the communication, and like Dr. Smith-Bindman had shown, you have to explain why it's important for our patients. And you want a patient to be able to go to one site and then go across town to another site and have the same quality exam, the same exposure, the same result based on their body size. So this was our first stab at this, and this happened a while ago. Sort of at the same time that we standardized, we also started participating in the ACR dose index registry, and we benchmarked our process to other national sites, and then we turned it on. And we weren't successful at first. And this is what our workflow looked like initially. We had CT workflow that was disconnected from dose monitoring workflow. And it basically went into a dead end. And so we soon realized that, okay, we had established what our standard work was going to be. We have a monitoring system. We had to actually use it. And so the next thing that we did was we built this workflow, which holds the front staff accountable for a portion of the dose alerts, and then it builds in a back-end process. And so as you can see, the CT room workflow is still independent, but the dose information goes to our dose monitoring software. And if there's an alert that's triggered, the way we built it was that the techs respond. And similar to Dr. Pike, we like to have our techs respond the same day. That way they can check the scanner. And if there's any evidence that needs to be looked at on the scanner, they can determine what was the deviation. And this required a lot of work. We had to educate our frontline team. But the big question that we had them ask was, is the protocol you're using matching what we've established for standard work? And if it's not, well, then we need to make sure that your protocol is set up to match the standard. And this was by far the majority of where our deviation from standardization was initially. And I'll show you some of that because I have some of the same kinds of Pareto charts that Dr. Pike has. So just to recap, we basically tasked the frontline staff for doing the initial response to dose alerts. It required a lot of training so that they could identify the protocol settings and what they should be and how they deviated. And then we had to give everyone training on how to identify factors that may be unrelated to the protocol. And we ended up with just a simple checklist that looks like this. And you can see that, one of the most frequently checked boxes for us initially was that the protocol parameters didn't match what we had in our online repository. And then we established objective criteria for each of these other categories, including large body habitus. This isn't just an eyeballing it. We've asked the staff to actually look at the water equivalent diameter, and we've set a threshold for large body habitus based on what our curves look like for our institution. So the techs do the apparent cause analysis. They check what they think is wrong. We had to make sure that they understood dose reports, and this is important because the structured dose report has to go to our dose monitoring software as well. And so this is part of our QC check for every exam. Things like, identifying if the Smart Prep series ran too long and the CTD eyeball is way high because of it, or if there were multiple acquisitions. or if the protocol, for whatever reason, is assigning the wrong phantom to that particular protocol. You can see here there's a duplicate scan for a part of the anatomy. And this all we did in multiple sessions, or we would visit locations and do small group sessions with the frontline stakeholders. This took a lot of work. And as you can see, this was just the beginning of our process in 2014. So when we asked the team to troubleshoot alerts, first thing we asked them to do was, did you use the right protocol? And if the wrong protocol was used, why was it? Did they have to add multiple protocols? And if that's the case, we have sanctioned combo protocols that can be used. And then it goes down the checklist. Was the positioning optimized? We have a lot of sick patients, and as you can imagine, a lot of patients with the arms down. And that has, as time has gone on, been one of our higher percentage categories, and I'll show you that data here in a second. But we do have a standard. We use water equivalent diameter to objectively state if we think the patient size was the issue, and to identify our outliers when we're doing the alert checking process. So this is one of our first 6-month reviews, and you can see on this Pareto chart in the far left, this deviation category, protocol doesn't match our standard book, was about 90% of all of our defects. And so that got us scratching our heads, right? We had done all this work communicating what we expected, establishing what best practices were. We were really proud of what was in our protocol book. We thought those parameters were good. They were going to provide good image quality, and it would provide standard work for everyone. But we could not get site-to-site compliance, and so we struggled with this for a while, including 2 or 3 6-month periods where we did dose alerts, and the protocol just didn't match. And so we went through that, and this became a metric for us. We wanted to track how many of our dose alerts were because the protocol wasn't the one we were expecting the staff to use. And we were able to get this down, and I'll show you how we did this. We decided that as an institution, we had to touch each one of our protocols together. And so what we started was a protocol of the week process. And this was really an effort that served 2 purposes. One, it would bring us sort of into standard work across all sites, but also it would satisfy the requirement from the Joint Commission that we review all of our protocols over a certain period of time. And so you can imagine, we have about 150 protocols. We get 52 weeks in the year. Sometimes we double up on the protocol of the week, but we basically push out every week one specific protocol that we want the teams to look at and make sure that they're doing it in the expected way. And you'd be surprised at what you would find on the scanner. But this was an opportunity for the teams to get rid of those weirdly named protocols, the ones that were one-offs or special exceptions for Dr. So-and-so from the ER, and to really get with the standard naming convention, make sure the parameters were inputted correctly. And then we had a spreadsheet that we checked that had all of our contacts, including the administrative support and the frontline operational person for that particular piece of equipment. And this was extremely powerful. And so this is what our timeline looked like. prior to this 2015 go live for the protocol book, that's when we had standardized the naming convention and collected all of our parameters. We started acquiring dose alerts mid 2015. That flow chart that I showed you with the new dose alert process happened at the end of 2015. And then sort of mid 2016, we started protocol of the week. And I have another run chart here that shows another drop in the line. And we saw good success with that. I had showed you the graph. Basically, the number of alerts that we were getting related to a protocol mismatch dropped significantly. As our volume picked up and our system grew, we did see some spikes in the percentage of exams that were alerting. There's a couple of caveats to that. Between 2018 and 2019, we adjusted our thresholds based on a refresh of data from the dose index registry. 2019 to 2020, we acquired multiple new hospitals that weren't previously part of our system. And so there was a learning curve with that, and we had to find resources to push to those other sites so that we could get the same standardization. One of the things that I love that our medical physicist team did, and I was speaking about this in the morning session earlier, we now have a standard operating procedure for whenever we bring a new piece of equipment into the mix. And our medical physicist team will be on site. They'll, if possible, upload a configuration that they have from a similar like scanner, and they will make sure that our protocols are named in the same way and the parameters are all what they should be. And so one of our more recent, and this was more recent, but the one that we just went through looks very similar. You can see that now we're down in sort of the below 10% of protocols that don't match what our expected standard work is. And now we have a larger percentage of alerts that are triggered due to the fact that, we consider the body habitus to be sort of out of range, or that we had a positioning issue. Some of our sickest patients, like I said, the arms were down in the beam. We've been focusing on this slice of the chart, the no findings. For exams where we thought, wow, everything looks right, but we still are having outsized alert events. And so this comes to the point that Dr. Pike made earlier. You've got the correct protocol, the positioning looks correct, the patient size is not a problem, and we didn't scan through the body, more than the once. What's going on? And one of the things that I find super powerful is having these graphs here that are a combination of water equivalent diameter on the x-axis and then some sort of exposure measure on the y-axis. And so this was a graph from one of our sites that had 3 different pieces of equipment, very similar. And these are all like protocols that scan through the abdomen. And you can see that this outpatient scanner in yellow was performing in a much tighter range than our orange and green scanner. And the parameters were the same, or so we thought. And lo and behold, we found out that one of the scanners had a software update, and that update affected how the dose modulation worked. And there was actually a setting where you could change the dose modulation curve from strong to average, and you can see what that looks like here. Under the strong setting, current would ramp up in a more aggressive way for our larger patients. And so by moving that back to the average setting, we were able to bring that scanner, the green scanner and the orange scanner, those 2 scanners, back more in line with our yellow scanner. And you can see the difference here. A lot fewer patients here that are sort of above that 30 milligray line. Still not perfect, but this is a great way to track what your variability is across the different body sizes. And so this was a very powerful tool for us. So I'll just go through the lessons learned here. This was a 13-year process for us. And the lessons that we learned were that having the resources in place are huge. We wouldn't have been able to do this without a dedicated medical physicist team. We were able to acquire capital investment for both our dose monitoring software, the IT resources, and the data analysis that we needed. We had administrative buy-in to support the team and to prioritize. There was a period of time, sort of 2017, 2018, where the incentive paid to the department from the healthcare system was benchmarked to our performance in dose. And so that allowed for the administrative team to have more buy-in with this optimization process. In order to do this well, you have to define your standard work. And you have to have a process for monitoring that and actually making significant change. And then a big part of it is the leadership piece of your committee has to be able to generate buy-in. And one of the ways that we convinced the techs to embrace the change was, hey, if you follow the protocol of the week and you do this well for the next 6 months or so, it will eliminate 90% of those alerts that you're getting, to the point where your scanner is running exactly how it should be. And that seemed to go a long way. And we had lots of meetings with the frontline teams so that they could give input and let the committee know what was and was not working. And then it's super important to make sure that data is available, both real-time data, but then also aggregate audits, and that you have the tools for evaluating your data and really identifying the outliers, something that Dr. Pike showed really well in a couple of her examples. And then some of the things that I showed as well. The Pareto charts are powerful, but also those scatter diagrams that show your dose related to body size. In terms of opportunities, we currently don't have a way to set alert thresholds relative to a body size. And so as you can imagine, most of the alerts that we get are on the biggest patients who receive the biggest dose. But the patients who are on the other end of the scale, we don't have a way to know if they're outside what our expected curve of standardization should be. The other thing that we've struggled with over the years is sort of the data transparency with some of our vendors. The proprietary settings, like how much iterative reconstruction, or for example, what the dose modulation setting was for that particular scanner, don't readily come across in an easy way to aggregate in the DICOM header when you're looking in your dose tracking software. It's better, and sometimes you can pick through and find the DICOM tags, but it's not automated. And so automating that would be a huge help if you had full visibility over every setting that was available on your scanner. And then something that we lack currently at Emory, and this is something that I've wanted for a long time, I would love an objective measure of image quality. And unfortunately, we haven't been able to work with Alara but this is something that I hope will become readily available in the future for us. It will really allow us to dial in exactly the right dose for the for the exam that we need for that particular patient. Um, and then something that is a big sorry, I skipped here, is a big favorite of mine. Um, a lot of our scope gets funded because we can make the business use case that we are helping with workflow optimization. And we talked a little bit about this in our breakout session earlier this morning. But one of the things that I try to do with our frontline teams, I want to make sure that their job doesn't have unnecessary clicks, unnecessary trips back and forth. I want to make sure that they can focus on the things that are truly important. And so, in the Grady Health system, we see so many cases that require scans for trauma or stroke, and we just don't have the time to be doing extra work. And so what I have done is I've made it my mission to eliminate any unnecessary clicks, whether that's in the electronic health record, whether it's on the scanner, whether it's pulling medications from a Pyxis. And so some of those strategies involve, making sure that your screening form in the electronic health record is optimized. We've made several revisions on that end. We have ruthlessly cut MPRs out of most of our high volume protocols, and we now rely heavily on our PACs to do the MPR work for us in the display protocol. This saves 5 to 10 minutes from what our prior state was on every stroke patient that we have. We've made a big push at our institution to go to multi-use contrast. Not only does it save plastic, it saves contrast, it saves contrast dose to the patient, but it's faster. Techs aren't pulling a single-use file from the Pyxis. If you look at their spaghetti diagram going back and forth during the course of the day, it cuts their foot traffic by 50%, and it speeds each patient up by at least 5 to 10 minutes. So this is huge, since everyone is resource constrained. The more you optimize and the more you make the business use case for it, the more administration seems willing to put resources towards a team that can do this kind of work. And I think those conversations have to go together. So I also finished a little bit early. I want to just acknowledge that all of the work that we do at Emory couldn't be done without our medical physicist team. Both Rebecca Neal and Shamli Dharmana Akari have been instrumental in helping us create standard work. And I wanted to stop there and just get questions and feedback from you guys.
Matt, I just want to say that was an incredibly helpful and enlightening talk that sort of got into the details of how you have managed to really make huge strides in your quality improvement. I also want to acknowledge that Emory was also one of our close collaborators through our dose optimization work, really active. I'm going to share a quote, which I didn't know was from Emory, but clearly is from Emory, around your protocol of the week approach, which I think is really a fantastic way to go deep to a manageable amount. You didn't ask everyone to optimize every protocol every week. You focused. And I think that focusing made it sort of a manageable task, which I think is really, really interesting. There are a number of questions.
Oh, I just want to add to that. The protocol of the week, you can hit 80% of your practice just in the first, 2 or 3 months because of how concentrated we are in certain things. And so it really puts a huge dent in what you're doing. And then it gives you time to focus on sort of the less frequent work that you're doing.
So low-lying fruit, you're saying, like go where the money is to the protocols that are used so often. You can really
Yeah.
get most of the work done. I think that's
Yeah.
a really fantastic point. I think the number of protocols that it sounds like you're managing is smaller than some places. Some places have an inordinate number of protocols, which makes that optimization even more challenging. So I'm going to turn the Q&A over to you. Let me know if you can see the questions, and answer them. If not, then I can read
Yeah.
through.
Do you want me to start at the top?
That'd be fantastic.
Can you help us understand how you got the administrative leadership on board for resources and support? So part of it was that we decided early on we were going to tie dose management to incentive, and so that basically created buy-in at the higher levels of administration, and that required our chair to be on board for that. Luckily for us here, for a long time we had a vice chair of quality. That position is currently open, but that vice chair position was also given resources to build quality teams for most of our modalities, and that was also super helpful. And then, we were able to advocate early on for those capital resources that we need, the servers that we needed to run the Triad software to send our doses to the registry. And then we've had a long-standing partnership with our dose monitoring software company. Moving on, are there a lot of alerts in need of action because of deviation? So that pie chart that I showed you really changed dramatically over the course of the last 8 or 9 years. We struggled initially getting traction with the protocols not matching our book. And then once we had two full cycles of protocol of the week, the unmatched exams were really, 7 or 6%. And then what it became was positioning and, education with the front team about positioning. And then a lot of our deviations were related to things that were really outside of the team's control. Like the example I showed where there was a software upgrade that it took us a minute to get our eyes on. And that's why we had to make sure that we were looking at our data in a comprehensive way. To what degree I need to click done here, to what degree are the radiologists and residents involved in some of the education that you do, understanding dose reports? So our residents play a crucial role in protocoling for us. And so that standard naming convention that I was telling you about, that framework also exists in our protocol tool that exists in the electronic health record. It also exists in our dictation system, so that when we go to make a dictation, we match those so that the right dictation is going with the right exam. And then if there's ever an issue, if the techs need help, they're not sure what to do, it's an easy way to communicate between the two teams. The physician team can very clearly say, I need AB11, which is our GI bleed protocol. And then the tech knows exactly what he has to do. It's on there. All the series are set up. All of the contrast is set up. And then he can focus on, is the patient positioned in the right way? Is the IV working properly? Is my timing correct? And all of those things. Can you explain a couple of reference books? Step-by-step guide on CT optimization. We do a lot of A3 work here at Emory, and there's lots of books on that, on sort of industrial optimization. We take a lot of the same takeaways. We've got a great partnership in town with Georgia Tech. There's a lot of industrial engineers who partner with the School of Medicine to come look at our processes. One of the things I was talking about was those spaghetti diagrams that we were looking at. When you consider sort of all of the movement that goes into scanning one patient, there is so much room for improvement in just how the room is laid out, when you do things, how you do them. So lots of resources out there. I don't know that I have just one good step-by-step guide. I will say that I published our process. It is out there, and a lot of what we've done is available if you just look at it on PubMed. Can you explain what it means that a protocol doesn't match the allowable approved protocols? Why is it so hard to just eliminate those? Yeah, and that really comes to the scope of our system, right? We have two medical physicists. I get 1 day a week. When I was in this role, primarily, I had a 1 day a week allocation to help with this. But we have 40 scanners, and those 40 scanners are at 24 different locations. We needed a way to centralize what we thought was appropriate, and then empower those frontline teams to make those changes. And so that was our way of saying, we see that you're not there yet. We need you to keep going with the protocol of the week, and make sure that you're matching. And a lot of this was, the pitch isn't the same, or the current modulation wasn't at the same setting, or the noise index wasn't correct, and we just weren't seeing the performance that we were expecting. So that's it. That was the ultimate challenge, was to eliminate those outliers, and then to really create the buy-in for, we're going to do standard work at every site, and nobody is special or has an exemption, right? And we had a committee that involved all of our stakeholders that would allow us to establish exactly what we were going to do. It takes a lot of work. Almost there. Do all the technologists know what the limitation of the dose is, so they will recognize the problem when it occurs? Yeah. So for our dose reporting system, it sends the alert as soon as it crosses the interface. So as soon as that structured dose report hits that server, they'll get the alert in their email, and that way they can look at it in real time. And so that was my point. You need access to real-time data so that you know when there's an issue. We use the same sort of process for our QC for our scanners. We use an electronic reporting system that notifies of outliers, and that helps us sort of get a handle on things quickly. And are you doing qualitative review of image quality? Yes, absolutely. And this is where our division leads, those physician champions for each of the divisions, will review image quality. And if we have a protocol, let's say we've made an adjustment to our thresholds after we've reviewed the DIR data, and we're going to change an alert setting, and we're making a proposed change to the quality index to one of our protocols. We'll do a test run on a few pieces of equipment, and we'll have our division champions review for image quality and make sure that they're diagnostic. This was the big piece. We're not there yet at Emory. We would love to have sort of a subjective way to really look at what is an objective way to look at what our image quality is, so that we know how our equipment is performing automatically in real time, so that we don't have to do these subjective qualitative assessments. Those are all excellent questions. Oh, did you lose
Matt,
out?
Matt, can I ask one more question related to that? You've had a real focus on reducing the dose for exams. And the last question is wondering if you're doing qualitative review of image quality and you want to do more review of image quality, but subjectively, with respect to the physicians reading the exams, do you feel that the image quality has suffered, that there are more exams that are poor quality that need to be repeated or that have radiologists banging on your door complaining. Has that become a problem, or is that more of a theoretical problem in your mind?
So I will say, I read thousands of scans every year, right? Mostly my clinical practice is split between trauma imaging and neuroradiology. And the biggest issues that we have with image quality is patient motion. And then we have one vendor in particular who is super sensitive to isocenter. And if you get the head out of the head holder and out of position on the gantry, and so there are some team members at Emory who have even published on this. We use an AP Scout for planning with that particular vendor. And what happens is if you get out of isocenter, typically you drop the patient in the gantry, and then you get the double whammy of the scanner drops the amount of current that it's using, right? It may even select a lower kVp. And then, when the tube is at the 90 degree and 270 degree position, it's imaging through the bow tie filter. And all of a sudden your image quality goes out the window. And so those are really the biggest things: are position, patient motion, but otherwise, our dose has continued to drop. We're using more iterative reconstruction now than we have in the past. I would say that our doses on average are about a third of what they were when I started reading CT scans, and I would say the image quality is equivalent.